Alright guys, welcome back. Today we will discuss the fascia and muscles that form the posterior abdominal wall. The posterior abdominal wall is composed of the structures that you see here. The structures are listed from the deepest structure to the most superficial structure. The lumbar vertebrae and their intervertebral discs form the deepest part of the posterior abdominal wall. Kind of surrounding the lumbar vertebrae and superficial to the lumbar vertebrae are the muscles that you see listed. The psoas, which is really mostly the psoas major, the quadratus lumborum, and the iliacus. And then also the transversus abdominis, the internal obliques, and the external obliques, which are part of the posterior abdominal wall, and then also they wrap around and they're part of the anterolateral abdominal wall as well. The lumbar plexus is present in the posterior abdominal wall. The lumbar plexus is composed of the anterior rami of the lumbar spinal nerves. There are multiple fascial layers present, including the thoracolumbar fascia, which actually has 3 layers. It has an anterior, middle, and posterior layer. And this thoracolumbar fascia is the main fascia that we see in the posterior abdominal wall. The diaphragm forms the very top of the superiormost part of the posterior abdominal wall. And then most superficially, we have fat, nerves, vessels, and lymph nodes present, which are just deep to the skin subcutaneous tissue. The posterior abdominal wall is covered with a continuous layer of fascia between the parietal peritoneum and the abdominal wall muscles. The psoas fascia is the fascial layer that covers the psoas major. So if you look over here, this is the psoas major. The psoas fascia is this blue line that covers it. The psoas fascia attaches medially to the body of the lumbar vertebrae and then down to the pelvic brim as well. Again, it covers the psoas major, and laterally it's continuous with the transversalis fascia. This picture doesn't represent it well. I'll show you a better picture in a little bit. But the psoas fascia is going to continue over, and it's going to be continuous with the fascia that covers the transversus abdominis. And this muscle is the transversus abdominis. So ultimately, it'll form this complete fascial layer that separates these muscles from the parietal peritoneum and all of the visceral organs that are within. Superiorly, the psoas fascia thickens to form the medial arcuate ligament. Let me erase so that you can see it over here. Sorry, I changed slides too quickly, but let me get my pen. And we were talking about the medial arcuate ligament. And I told you guys that the psoas fascia superiorly thickens and it forms the medial arcuate ligament. I'll show you on this picture here, this, and then on this side, this, that's the medial arcuate ligament, right? And that's formed from the psoas fascia. And the little arch, this little like arch passageway by the diaphragm that it forms, That's for the psoas major. The psoas major actually passes through that. All right, so the psoas fascia is the fascial layer that goes over the psoas major, and we said it comes over and it's continuous with the fascia that covers the transversus abdominis, the transversalis fascia. Now, the thoracolumbar fascia is a really large fascia that's present in the posterior abdominal wall, and it has three layers: the anterior layer, the middle layer, and the posterior layer. The middle and posterior layers enclose the vertical deep back muscles. So here you see the erector spinae, and then you see the middle layer and the posterior layer enclosing the muscle. The anterior layer covers the quadratus lumborum, and so this muscle right here is the quadratus lumborum, and this is the anterior layer covering it. So the anterior layer, because it covers the quadratus lumborum, it's frequently called the quadratus lumborum fascia. It attaches to the anterior surface of the transverse processes of the lumbar vertebrae. So here you see this is the transverse process, and you can see that this again is the anterior layer. It attaches to the anterior surface of the transverse process. It also attaches to the iliac crest, the top portion, the top curved portion of the pelvis, and then also the 12th rib superiorly. As we head laterally, the anterior layer is continuous with the origin of the transversus abdominis and the internal oblique, really. But if you follow this over, you see that it merges down here, and this is the origin of the transversus abdominis. So looking at these muscles, the transversus abdominis, the internal oblique, and the external oblique. Okay, those form the lateral edges of the posterior abdominal wall, and then they form a lot of the anterolateral abdominal wall as well. Superiorly, this anterior layer, or quadratus lumborum fascia, thickens and forms the lateral arcuate ligaments. So those are just lateral to the medial ones. So again, if you look at this bottom picture, you see the diaphragm and the posterior and inferior surface of the diaphragm. This is the lateral arcuate ligament over here, and then you see the other one over here. So the psoas fascia forms the medial arcuate ligament. The quadratus lumborum fascia, or the anterior layer of the thoracolumbar fascia, forms the lateral ligament. And the quadratus lumborum passes through like this little arch right here, or the little arch that kind of fits around. The middle and posterior layers of the fascia, again, we said enclose the deep back muscles. The middle layer, which is why I have the little M here, the middle layer attaches medially to the very tip of the transverse process. So the tip, and you can see that right here. Again, this transverse process goes out to the sides, and then the medial layer attaches just to the tip of it. So the anterior layer attached to the anterior surface, the middle layer. The middle layer attaches to the tip, and then we'll see the posterior layer attaches to the spinous process. So looking at this lumbar vertebra, this is the spinous process. And so you can see the posterior layer attaching to the spinous process, and then the other side as well. Laterally, they merge and again attach to the internal oblique and transversus abdominis. So again, if you look right over here, you'll see how all of these layers, the anterior, middle, and posterior, they all kind of start to come together here. And then you can see the origin of the transversus abdominis, and then just superficially the internal oblique. Okay, so here we can kind of see all of this. If you look at this picture right here, just to kind of get your bearings with the muscles, you have the deep muscles of the back right here, the quadratus lumborum right here, and then anterior to that, the psoas major. So the psoas fascia you see is this dark blue line that covers the psoas major. And this is a good picture. This shows how that fascia continues laterally and connects to the fascia that covers the transversus abdominis. And it forms this nice fascial layer that separates the posterior abdominal muscles from the peritoneum. So you can see the peritoneum is right here. So we have a nice border in between. And then going or moving more superficially, moving back from that, you see the thoracolumbar fascia, the anterior layer, and then the middle, and then the posterior layer. And they come over and attach to the origin of the transversus abdominis, the internal oblique, and the external oblique. Here you can just kind of see the transversus abdominis, internal oblique, and external oblique. You see how they form the very lateral most portions of the posterior abdominal wall, but then they curve around and form the anterolateral abdominal wall as well. Back here, the psoas major, quadratus lumborum, and then we have whatever deep back muscles. Here, this is just showing you again the different fascial layers, and you can see how this just shows the thoracolumbar fascial layers. It's not showing you the psoas fascia, but you can see the, you can see the anterior coming over to connect to the transversus abdominis. You can see the middle and then the inferior. The psoas major and iliacus are two of the major muscles in the posterior abdominal wall. Together, the psoas major and iliacus are referred to as the iliopsoas. So the iliopsoas is both of them together, the psoas major and iliacus. They can be separated though. The psoas major is the muscle that you see right here, and then this top part. The psoas major attaches to the transverse processes of all 5 lumbar vertebrae, and then the sides of the bodies of T12 through L5. Some references will say S1 as well. So looking at this, you can see it attaching to the transverse processes of the lumbar vertebrae, right here, 2, 3, 4, and 5. And then also to the vertebral bodies. So this is T12 right here, and you can see it attaches to the body. So it's attaching to all the bodies as well. And then it kind of, all of these fibers merge together and it thins out as it heads down and into the very, very top of the femur. The psoas major attaches to the lesser trochanter of the proximal femur. So you can see it continues down and attaches to the lesser trochanter right here. Remember, the femur has 2 kind of large bumpy processes, the greater trochanter and the lesser trochanter. The iliacus goes along the, or extends from the lateral sides of the inferior portions of the psoas major. So you can see it here. Okay, it's going out laterally, from the psoas major. It attaches to the top 2/3 of the iliac fossa. So the iliac fossa is the little depression in the ilium up here. And then also to the ala of the sacrum. Those are like, you can't see it in this picture, but they're like the big, like the wings of the sacrum. It extends down inferiorly and joins the psoas major and also attaches to the lesser trochanter at an F of the femur. So you can see they both come down together and attach to the lesser trochanter. They work together, so functionally, they both flex the thigh and then also flex the trunk when sitting, primarily. The quadratus lumborum is located just adjacent or just lateral to the transverse processes of the lumbar vertebrae. So looking at this, you guys can see the lumbar vertebrae. 1, 2, 3, 4, 5 here. And just lateral to the transverse processes, you can see the quadratus lumborum. So it's also located just lateral to the top portions of the psoas major. It's connected to the inferior border of the 12th rib. So you can see the 12th ribs right here, and you can see it connecting to the inferior border. And then also to the very tips, those lateral tips of the transverse processes of the lumbar vertebrae. Inferiorly, the quadratus lumborum attaches to the internal lip of the iliac crest. So the iliac crest, again, is the large curve on top of the pelvis or on top of the ilium, and just the internal lip of that is where the quadratus lumborum connects inferiorly. Here you can see all three of the major muscles of the posterior abdominal wall. The quadratus lumborum, again, connects to the bottom of the 12th rib. The transverse processes of the lumbar vertebrae, and then you can see the inferior connection here to the inside or the anterior portion of the iliac crest. The iliacus, you can see right here in the iliac fossa, and then continuing down to the lesser trochanter of the femur. And then the psoas major. You can see coming down and then also connecting to the lesser trochanter. The lumbar plexus of nerves are located in the posterior part of the psoas major muscle, just anterior to the transverse processes of the lumbar vertebrae. The lumbar plexus nerves is composed of the anterior ramming of the L1 through L4 spinal nerves. All of these anterior ramming receive gray communicating fibers or branches from the sympathetic trunks. The branches from the lumbar plexus of nerves include the obturator nerve, the femoral nerve, the lumbosacral trunk. These three are the largest, so we're going to talk about them in more detail on the next few slides. The ilioinguinal and iliohypogastric nerves come from the L1 spinal nerve. The genitofemoral nerve is from L1 and L2. And then the lateral cutaneous nerve of the thigh is from the L2 and L3 spinal nerves. Here we see the lumbar plexus. So all of this is the lumbar plexus of nerves. Below that is sacral. You can see them over on this side here because the psoas major has been removed, right? So over here, when the psoas major is in place, they're located in the posterior portions of that, so we can't really see them. We've got to actually remove the muscle, and then we can see the lumbar plexus of nerves. If you start up at the very top, right here, this branches, and the iliohypogastric is up top. The ilioinguinal is on the bottom. Both of the ilios supply the muscles and skin of the pubic and inguinal regions. The genitofemoral nerve, you can see just the very beginning right here. It actually, inferiorly, it splits, and it has femoral branches and genital branches. Over here you can see the genital branch coming through the psoas major and then progressing down towards the genitals. The lateral cutaneous nerve of the thigh, you can see right here, right, rather large. The lateral cutaneous nerve of the thigh enters the thigh. It crosses through just behind the inguinal ligament, that large ligament that stretches across the inguinal region. So the lateral cutaneous nerve of the thigh passes just posterior to that inguinal ligament, and it supplies the skin on the anterolateral aspect of the thigh. It's like the front and side of the thigh. So I said that we would go into the obturator nerve, the femoral nerve, and the lumbosacral trunk in more detail. Just kind of looking here, you can see the L1 spinal nerve, L2, L3, L4, and all of those are going to be important for both the obturator and femoral nerve. The obturator nerve is formed by portions of the L2 through L4 spinal nerves, and you can see here, this is the obturator, and it has there and there and there. The obturator nerve emerges on the medial side of the psoas major, so it's more medially, and it passes from the pelvis into the medial thigh. And looking at it, you can see that the psoas major would be like right here, and the obturator nerve comes right here. It passes through the obturator foramen, obturator in the pelvis, right? That's that big hole in the pelvis, and comes into the medial thigh, which is where the adductor muscles are. So it supplies the adductor muscles. The femoral nerve is also from the L2 through L4 spinal cord segments. It actually emerges on the lateral border of the psoas major. So, and you can see this is this large one here, and it goes 4, 3, and 2, comes down to the femoral nerve. The femoral nerve passes, or it innervates the iliacus, which is over here. And then it passes deep to the inguinal ligament, and this long white thing right here is the inguinal ligament, so it passes just deep to the inguinal ligament, into the anterior thigh. So you see it right here, the anterior thigh. So it innervates the flexors of the hip and the extensors of the knee, which makes sense anatomically when it's going to the anterior thigh. So the obturator nerve passes through the obturator foramen to get down into the leg. The femoral nerve passes deep to the inguinal ligament to get down into the leg. The obturator nerve goes in medially and participates in adduction. The femoral nerve goes anteriorly and participates in flexion of the hip and extension of the knee. The lumbosacral trunk is the last of the really large nerves that we'll talk about. The lumbosacral trunk is formed from the L4 and L5 spinal nerves. Just looking here again, remember we said we have the L1, L2, L3, L4, which L4 is also shown over here, and then L5. So L4 and L5 come together, and that gives us the lumbosacral trunk. Lumbosacral trunk because it ends up connecting the lumbar spinal nerves to the sacral spinal nerves, or the lumbar plexus to the sacral plexus. The lumbosacral trunk passes the ala of the sacrum, which again is like this big wing of the sacrum, and then it, once down in the pelvis, the true pelvis, it joins the anterior rami of S1 through S4, and you can see that happening right down here. These are the sacral nerves, and the lumbosacral trunk comes and joins them, and then we have the sacral plexus. Eventually, fibers from these nerves are going to pass down into the leg, forming the sciatic nerve, which you see here, this really large nerve passing down through the leg. And the sciatic nerve is going to be incredibly important clinically. We'll talk about that more in a later lecture. A psoas abscess refers to pus accumulation in the psoas compartment. What we mean by psoas compartment is within the fascia that surround the psoas. The most common way for psoas abscess to occur is from passing from infection in the lumbar region. For example, tuberculosis in the lumbar region can pass into the fascia around the psoas and can cause psoas abscess. Tuberculosis can actually affect multiple other tissues besides the lungs. We typically associate it with the lungs, but tuberculosis can actually infect multiple other tissues, including the spine. When we talk about the psoas and tuberculosis spreading to the psoas, this happens from the lumbar region because remember the psoas fascia connects to the lumbar vertebrae. So infection in the lumbar vertebrae can pass directly from the vertebra into the fascial sheath. And then we can have infection and pus accumulation happen in the psoas compartment. Also, if tuberculosis or some disease is present in the thoracic vertebrae, it can also pass to the psoas fascia more superiorly through the mediastinum or mediastinum, but this is not as common. Typically, it happens when the infection is present in the lumbar region. Again, because the fascia connects directly to the lumbar vertebrae, so it's a really close, easy jump from one to the next. When psoas abscess or infection and pus occurs in the psoas fascia, the fascia tends to thicken to form a rather immobile, strong tube around the muscle. This can be problematic if pus accumulates and starts to compress the muscle, and then that can lead to actual necrosis. When pus accumulates in the psoas compartment, it tends to kind of accumulate and then because of gravity drip down inferiorly. It will travel down over the pelvic brim and then deep to the inguinal ligament into the leg. Remember, think about the attachment of the psoas major. It continues down into the leg and attaches to the femur, into the lesser trochanter on the femur. So the pus and infection can just travel down through the compartment into the leg. So the pus typically ends up surfacing in the superior thigh, so in the thigh or also in the groin at times. Treatment involves drainage of the compartment to remove the pus and to relieve the pressure on the psoas muscle. The iliopsoas muscles are closely related to the kidney, the ureters, the cecum, the appendix, the sigmoid colon, the pancreas, nerves, lymph nodes. A lot of different abdominal pelvic organs are closely related to the iliopsoas. Injury to any of these structures is associated with pain in the iliopsoas with movement. We can utilize that to test for an injury and increased intra-abdominal pressure that's associated with the injury. The iliopsoas test can be performed, and then a positive test indicates that yes, there is some sort of injury and pressure increase in the abdominal pelvic region. For the iliopsoas test, the patient should lie on the unaffected side. So we can't say necessarily on their left or on their right. It just depends on what you suspect or where you suspect the problem is. So for example, for the appendix is on the right. So the person would lie on their left side. The person lays on the unaffected side and they extend the thigh. So the thigh is pulled backwards while the practitioner puts counter resistance on the hip. So the hip is held in place while the thigh is extended back. If there's pain when this movement is executed, that's a positive psoas sign. So, for example, we just used the example of the appendix. An acutely inflamed appendix will produce a positive psoas sign. An aneurysm is a local enlargement or bulge in a vessel wall that occurs due to weakening of the elastic fibers in the vessel. Typically, vessels, especially those that are under a lot of pressure, are stretchy. When the pressure goes up, they just stretch, and then when the pressure is not so high, they constrict back to normal. And this way the pressure doesn't damage them, right? If the pressure goes up really high, the wall doesn't get hurt, it just stretches out. When there's a weakening of those elastic fibers, all of a sudden that part of the wall can now be damaged by high pressure, and it starts to bulge, it starts to push out due to the pressure of the blood pushing out. That bulge is an aneurysm. The problem with aneurysms is that they can rupture, right? That weak part of the wall can burst, and then at that point there's a lot of blood loss. When there's an aneurysm in the abdominal aorta, this is especially problematic because the aorta is so big, and the blood that's in the aorta is really pressurized. It's relatively close to the heart, so there's a lot of pressure pushing out. So a ruptured aneurysm in the abdominal aorta is extremely dangerous because there's so much blood loss that happens really quickly. If the aneurysm in the abdominal aorta ruptures, it causes severe acute pain in the abdomen or the back. An unrecognized abdominal aortic aneurysm has a mortality rate of around 90%, which is extremely high. And again, this is just because of the severe blood loss that occurs upon rupture. Surgical treatment of an abdominal aortic aneurysm involves insertion of a prosthetic graft and then sewing the wall of the aorta over it in order to strengthen that area that was previously weakened by the aneurysm. An abdominal aortic aneurysm now can also be treated with endovascular catheterization, which I'll show you guys on the next slide. Here you see both different ways of treating an aneurysm in the abdominal aorta. Here you see a great bulge that's present, and again, that weakens the walls. If that were to rupture, extreme blood loss would happen very, very rapidly. Here you see the vessel being opened up and a graft being stitched in. The vessel's clamped on either side. It's opened. Here's the synthetic graft. You see that it's attached on either side, and then the wall of the vessel would be be restitched around that. This is the endovascular repair. The stent is just placed inside the vessel to go over, or I guess not over, but through, to go through the area where the aneurysm was previously.